So the topic assigned to me was coarctation of the aorta. I have no disclosures. So just briefly, we all know it's quite a common disorder and not as uncommon as we think it is. And mostly these patients will present in infancy and children. But in our part of the world, seeing these in adults is quite common, I would say not uncommon. So there's a wide morphology of spectrum of disease with this disorder. You could get a discrete lesion to a more of an interruption, and you could even have a focal disease to a more of a tubular. And sometimes post-coarctation, you could have pseudoaneurysms and patch aneurysms. The implication of these presentations lies that it can occur in neonates and young children, usually present with heart failure and claudication. But we do see a lot of patients who are asymptomatic or present with hypertension in the clinic, and they're diagnosed to have coarctation. And the importance of this lies that if you don't tackle them, their lifespan decreases, and most of the time they die because of cardiovascular complications. I think this term is something which is very important, the variance of coarctation. It was first described by Perloff, but if you look at it, it's just not coarctation alone. Though around 30% you would get coarctation, but there's a wide gamut of diseases that you would associate it with this, such as the vascular ring. The image on the side is actually a 12-year-old young girl who presented, and we operated on her around 4 years back. So she has a double aortic arch with a coarctation. And if you look at the terminal abdominal aorta, you can see it's not normal, it's a disease. So these patients present with a wide gamut of disorders, which are well known, are aneurysms in the brain. Quite a few of them have bicuspid aortic valves, and they can even present with aneurysms and dissections. So it's important as we as clinicians that look at the whole spectrum, although a patient may just present with a coarctation. This is from the data from the National Heart Center in Nepal for a decade up to 2018. We looked at these coarctation in infants and in neonates, infants, and young children, and we found that isolated coarct was present in only less than 50% of these patients. They had some associated anomalies. And then with adults, in our series, what we found is there's a wide gamut of associated anomalies with these patients, varying from septal defects to bicuspid aortic valve in 1/3 of these patients, and some of them even going on to develop moderate to severe aortic valve stenosis with aneurysms in the ascending as well as the descending aorta. And actually in our series, though not related with coarct, there were 3 patients who had associated rheumatic valvular heart diseases. It is well regarded that coarctation is also associated with coronary artery disease in adults. And what is well recognized that these patients will present with a MI or would require some form of intervention much younger than when compared to patients without coarctations. So just briefly on the treatment modalities, with the advent of endovascular treatment and the gross increase in this, there are a lot of editorials that come out with whether surgeons are actually now required. And it's based on a lot of manuscripts that have come out initially with manuscripts such as this, where though a small series, they had 100% success, no access site complication, no paraplegia, no requirement for blood transfusion, no mortality, dissection, or a stroke, and these patients were discharged on the first postoperative day. So it's almost uncomparable for a surgeon to compete with this. And then if you look at these meta-analysis, which include centers in China, where they looked at covered stents, and they also had excellent results with treating coarctation, and they concluded that it was safe and effective with a high procedural success and a low incidence of recoarctation. Then another one from the Cleveland Clinic with Dr. Roselli and his team, they looked at open endovascular and also a small number with hybrid. What they found was that the procedural risk was very minimal with endovascular, and the hospital stay was much less compared to open techniques. But of course, the reintervention was much higher with endovascular as compared to open. And one of the defining trials for endovascular treatment was the COAST trial, And what I feel is I think patient selection is key to doing endovascular treatment in this diseases. So if you look at the exclusion criteria, so it was not done in elderly, it was not done when there was connective tissue disorders, or there were other sort of complications, or there was issues with the arch of the aorta. And I think that is, the key to having a good result with endovascular. Of course, you worry about aortic wall injury, which is much higher with stenting, and the incidence of reintervention is higher. And of course, there's worry about vascular wall injury to the access vessels as well. So this is an editorial with regards to the COAST study. So what they felt was that, of course, the Chatham platinum stent, the covered stents, had a better result compared to other forms of treatment. And this, what they concluded was there is a concern when you have a hypoplastic transverse arch. So at present, there are a large number of series that have looked into the endovascular treatment. One on your left is the from the US, and the other one is from Europe. And what they've all concluded is though that for nascent coarctation of aorta, newly diagnosed, the complication risks are much less, but there is a small infrequent risk of aortic rupture. And of course, the incidence of reintervention does remain with endovascular treatment. So at present, what I believe is it is a choice now, especially if it's become a first choice for simple and in adults. But of course, there are a lot of things that you have to look at prior to using this as the first choice. And also serves as a good choice when you need it as a hybrid procedure. But limitations of that is, of course, there is the risk of injury to the walls. The requirement of reintervention is high. There's not much long-term follow-up data on it. The course had intermediate results published in 21, which was just a 5 years follow-up. And of course, it requires a favorable anatomy, and you cannot offer it in neonates and children, young children, because of vascular access itself. Now, coming to the surgical techniques, there are various techniques that are well recommended and we're all aware of, from resection to extended resection and end-to-end anastomosis, placement of a graft, extra-anatomic bypasses, and even patchplasty. These are just some of the images that we've done in our center, especially with adults. It's important that you look at collaterals, and most of these in adults would require interpositional tube graft compared to a resection, while in children and neonates, it's easier to do a end-to-end or extended end-to-end. The new guidelines from the STS for neonates and young infants advocate surgical correction. And of course, that's important that you look at the arch of the aorta, because some of these patients do present with hypoplastic arch, and it becomes important that you choose the right approach, especially if there's significant arch hypoplasia. These patients may require a sternotomy as opposed to a thoracotomy to repair these coarctation. Our experience with adults, so most of these patients, like I mentioned, we've done interpositional tube grafts. Some we've been able to do an end-to-end, and some patients have required extra anatomic bypasses. This is well documented. This is from the Mayo series in 2011, where they had done on 50 patients. There's no mortality, there's no late graft-related problems, and we've a small series of, we've done 3 for coarcs, maybe 5 or 6 overall. Amongst our series, there were 2 patients who had a root and ascending aortic aneurysm, and there was a patient who had a aortic valve stenosis with a low EF and had a coarctation as well. Of course, there are concerns with this ascending to descending bypass. I've done one for a cervical arch on a 8-year-old child, came for follow-up around 7-8 years back. After 7-8 years back, this has been doing well, but of course, there's the issue of in growing adults. And then when these patients are usually present with associated anomalies, a re-entry and planning a resurgery on these patients is much, much more complicated as opposed to a straightforward aortic valve replacement or other coronary surgeries. We've used the heart-lung machine or the left heart bypass in a few patients. Our indications have been when they're associated with a descending aneurysm, or you have to resect a big segment of the descending aorta while doing a coarct. When there's hypoplastic arches and needs extensive repair, we've found it easier to go on bypass and extend up onto the arch. And of course, when there's you need to sacrifice a large number of intercostal collaterals. Uh, there are a lot of manuscripts where you could look at clamp and you could measure the pressure. We do plan this early, especially if there are a lot of collaterals. And usually, majority of adults with coarctation, when they're present, you don't need any form of these support because they tend to have good collaterals and they tend to have, so that protects the limbs and the viscera and the spine. I thought there would be quite a few cardiologists, so I just wanted to mention this on the mystery of recurrent hypertension, especially with coarctation of aorta. We all know the various mechanisms that are thought to occur with hypertension and coarctation. There are few risk factors such as the time since repair, especially when you repair them in older, when you use a prosthetic material, or when you don't do an end-to-end anastomosis. Hypertension is known to persist. It's also quite recognized that 1/3 of these patients with coarctation following repair do tend to have high blood pressure, and age is regarded as one of the criteria. So in our series that we looked at, we did find that the presence of hypertension did decrease following treatment of coarctation of aorta. And what we did find was that almost 50% of these patients would require antihypertensive treatment, especially with even injectable antihypertensive in the immediate postoperative period to control their pressure. And when we looked at the predictors, what we found was only the interpositional tube graft was a univariate predictor for persistence of hypertension. And what we believe is hypothesized is that basically the graft is non-pliable as the elastic aorta, and that allows it to cause hypertension. Just briefly on the recoarctation, it does occur even following surgical intervention, though it's higher when you do endovascular. Age of repair is an independent risk factor for recoarctation. And in these patients, intervention with endovascular treatment may be considered. In our patients, we've had 2 patients that have recoarcted. One has undergone endovascular repair, and the other one actually we lost to follow-up. So in conclusion, primary coarctation in infants and children are quite common. And in adults, it is common in our part of the world, maybe less so in the first world. And it's primarily because of underdiagnosing these patients. Stenting and surgery have similar results with simple coarctation, but surgery would be the choice if it's less risk, and the chance of reinterventions and recurrence of coarct is low. It does help in control hypertension. And what is important with these group of patients is that though you fix the problem, these patients are not cured. So they do require long-term follow-up. And there's multiple and extensive evidence in literature that these patients may have complications later on. So even after coarct repair, these patients need your follow-up. I'd like to conclude my talk. I'd like to invite you all to visit Nepal. It's considered the roof of the world, and it's in the middle of Asia. I'd like to thank the organizers again for the invitation, and I'm happy to take questions.